Okay, guys, so we are back after sort of a long break, back to Drug Club Oncology. And we're going to start off with prostate cancer, which is a topic that a lot of you requested. So before we get into the topic proper, we're going to talk about a brief overview of the systemic therapy in prostate cancer. Okay, so that's the topic for today: systemic therapy, systemic treatment in prostate cancer. Right. So when you talk about systemic treatment in prostate cancer, I'm going to talk about the drugs, how they're given, the side effects, etc., and a little bit about the indications. But we're going to get more into the indications in the coming classes. Okay. So when you talk about systemic treatment, we have to start off with ADT, that is androgen deprivation therapy, right? That is the cornerstone or the backbone of treatment of prostate cancer, especially in the metastatic or advanced setting, right? So ADT, right? Why do we need androgen deprivation? So, if you look at CA prostate, it is mostly testosterone dependent growth in CA prostate. Okay. So, what happens is you have the hypothalamus, which secretes GnRH, right? Which acts on the pituitary, right? And now from the pituitary, you have luteinizing hormone and you have ACTH, right? Now, this luteinizing hormone acts on the Leydig cells within the testis, right? And by virtue of action on the Leydig cells, it releases testosterone. Now, this testosterone gets converted by an enzyme called 17 keto reductase to dihydrotestosterone. And this is the culprit here. This dihydrotestosterone binds to the androgen receptor on the prostate cells, right? And this androgen receptor gets internalized to the nucleus, and this leads to the proliferation of the prostate cells and into them turning malignant, and it leads way to prostate cancer. Okay, so that is the mechanism. Now, this is through the testes. There's another mechanism through the adrenals, right? So this ACTH that's secreted from the pituitary that goes and acts on the adrenals, and within the adrenals, via the help of an enzyme called CYP17, it produces two types of testosterone, that is androstenedione and DHEA. Now, both these hormones can be converted into dihydrotestosterone as well. So, both these hormones also lead way to the development of prostate cancer. So, this is the basic pathway by which prostate cancer develops. That is through the formation of dihydrotestosterone, which then acts on the androgen receptors on the prostate cells and leads to the proliferation and development of malignancy. Right. So, that is why it's of paramount importance to deprive this androgen supply. So, how did we used to do that? Earlier, there were we used other techniques. Currently, we have a separate set of treatments. So earlier, right. So earlier, what we did was we did bilateral orchidectomy, and then we also use high dose estrogen. Right, high dose estrogen will cause feedback inhibition of the hypothalamic and pituitary hormones. So that was used. Even diethyl stilbestrol was used. And another technique that was used was ketoconazole. So ketoconazole is actually a P450 enzyme inhibitor. Okay, so cytochrome P450 enzyme system of enzymes is inhibited, and that leads to less production of dihydrotestosterone because these enzymes are needed for the production of DHT. Okay, So these are the techniques used, but a lot of these techniques were crude, they were permanent, they had multiple side effects. For example, high dose estrogen can cause thromboembolism, right? And because of the side effect profile and the toxicity of these treatments, we looked for better treatments. And that's how luteinizing hormone releasing hormone agonists came along. Okay. Now you might think this doesn't make any sense, right? You're actually promoting the release of more LHRH. But what happens here when you give an LHRH agonist? Let's look at what happens. So basically, as expected, initially, because this is a gonadotrophin releasing hormone, right? So basically, what happens initially, so this is also known as GnRH agonists, right? Initially, there's a surge in testosterone. Okay. And initially, the surge in testosterone is seen for 2 to 3 weeks. And following this initial surge in testosterone, there is feedback inhibition. Because of this huge surge, there is automatic feedback inhibition of GnRH release. Okay. But that will take around 2 to 3 weeks. And not only that, there is a downregulation, downregulation of pituitary GnRH, more specifically LHRH receptors. So, although there is a initial surge in the levels of testosterone, in 2 to 3 weeks there is feedback inhibition of GnRH release from the hypothalamus and downregulation of the pituitary GnRH receptors. Right. So, here one thing that I have to tell you is that because there is an initial surge in testosterone, you should always give a first generation anti-androgen, right? That is usually we give bicalutamide, 50 milligram OD for at least 2 weeks to tide over that initial surge in testosterone. Okay. So that we always prescribe bicalutamide for 2 weeks when we start the patient off on GnRH agonist to tide over that surge in testosterone. Okay. So what are the GnRH agonists or LHRH agonists that we use commonly? Let's look at all those. So you have leuprolide, right? Leuprolide is given at a dose of 22.5 milligram deep IM every 3 months. Okay. You can also, there are formulations that also give it subcutaneously. So both ways formulations are there, although classically it is given deep IM. Then you also have goserelin. So goserelin is given at a dose of 10.8 milligram. This is given subcutaneously every 3 months. Now, apart from this, you also have triptorelin. This is given at a dose of 11.25 milligram, and this is given IM every 3 months. So these are the three most commonly used GnRH agonists, right? So apart from this, instead of using agonists, waiting for that 2 to 3, week period for that initial testosterone surge followed by downregulation, you can also give another set of agents, that is your GnRH or LHRH antagonists. So here there is direct blocking of LHRH. Okay. And because of the direct blocking, there's rapid decline in testosterone. Okay. It usually occurs within 24 hours. Rather than waiting for 2 to 3 weeks, it occurs in 24 hours. Okay. So there is no testosterone surge. You need not give biglutamide for a couple of weeks, right? You can straight away give it without biglutamide. And so, where do we use GnRH antagonists, right? So, we use it in situations where we need a rapid decline in testosterone, right? So, patients who are highly symptomatic, usually these are metastatic patients. So, patients who are highly symptomatic, right? Patients with spinal cord compression or impending spinal cord compression, right? Patients with urinary tract obstruction, okay? So all these scenarios where you need a rapid symptomatic response, you cannot wait for that initial testosterone surge and all that. There you can give GnRH antagonists. These act faster. They decrease the testosterone levels within 24 hours. So what are the agents given here? So we have two commonly used agents. One is degarelix. Degarelix is given at a dose of 240 milligram subcutaneous. This is given as a loading dose. And then monthly, it is given at a dose of 80 milligram subcutaneously every month. Now, apart from this, we also have an oral agent that is given, that is relugolix. Okay. Now, relugolix is given on the first day at a dose of 360 milligram on day one, and subsequently, it is given at a dose of 120 milligram OD, right? Subsequently. Okay, so this has to be taken on a daily basis. So, right. So, just to summarize antagonists versus agonists, you can see here if you look at the testosterone level and if you look at the time, so when you use an antagonist, right, there is direct suppression. So within 24 to 48 hours, the testosterone levels reaches its nadir. Okay. But in case of GnRH agonists, there is an initial surge which lasts for over 2 to 3 weeks, followed by the nadir being achieved usually by the end of 3 to 4 weeks. Okay. So there's that initial delay before the testosterone levels decrease with agonists. Okay. So you might think this is pretty straightforward, but these treatments do come with their side effects. So, what are the adverse effects of giving these androgen deprivation therapies? So, these include, and all of them are very important. You need to counsel your patients when you are giving androgen deprivation therapy, right? Because there's libido loss, there's erectile dysfunction, the hot flashes that are seen very commonly. Okay, there is muscle atrophy. Okay, there is weight gain. There can be hair loss or hair thinning. There can be fatigue. There can be depression. Okay, you can develop gynecomastia. Usually, they will, in case of the male breast, what you'll see is you'll see a hardening of the breast or formation of sort of like a lump, right? And you can also have osteoporosis. You can have hyperlipidemia. And there's also an increased risk for development of diabetes. There's an increased risk for MI, and there's also an increased risk for congestive heart failure. Okay. So, a wide constellation of side effects are seen when you give androgen deprivation therapy. Although most patients tolerate it, these side effects need to be counseled and kept in mind. Okay. So now, what are the prophylactic measures we can take? Prophylactic measures or treatments we can take. Okay. So number one thing is exercise. So mild to moderate exercise, especially if the patient doesn't have, you know, bone mets or metastatic disease that makes them vulnerable. If they don't have that, they need to be put on a mild to moderate exercise regimen. Now, another thing is for hot flashes, what we do is we can give either gabapentin, right? We can give medroxyprogesterone, or we can also give venlafaxine. Okay, these are the preferred agents. Now, when it comes to the cardiovascular risk, like I said, it can cause congestive heart failure, it can cause MI, right? So these are usually less with antagonists, actually, and they're more with the agonists. Okay, if you look at the incidence. Now, there's no medication as such, but we go for lifestyle modification. So, you know, smoking should be stopped, right? We can treat hypertension, we can treat diabetes, and we can give, control high lipids, right? So give statins and other lipid lowering agents. So all this can be done to curb the risk for cardiovascular complications. Now, another issue is the presence of osteoporosis or decreased bone strength. So these patients should be supplemented with calcium and vitamin D3 supplementation. Okay. So the recommended dose of calcium is 1000 to 1200 milligram. The recommended dose of vitamin D is 800 international units. Okay. So this should be supplemented along with ADT. Now, another question that arises is, what about bone strengthening agents? Right? What about bone strengthening agents? So this is, whether it's required or not, is decided upon by doing a DEXA scan. Okay. We look at a DEXA scan, we look for the presence of any existing osteopenia or osteoporosis. And once we have taken the DEXA scan and baseline, then we calculate something called the FRAC score. Okay. The FRAC score has to be calculated. It is the WHO fracture risk assessment tool. Okay. So it can be calculated online. And we look at the 10-year risk of hip fracture. Okay. So if the 10-year risk of hip fracture is greater than 3%, or if the 10-year risk of any major fracture is greater than or equal to 20%, there we prefer either inject, a bisphosphonate or denosumab, right? So either of those can be given based on the FRAC score, which can be analyzed by doing a DEXA scan. Okay. So that's how you decide whether a bone strengthening agent is required or not. And this DEXA scan should be repeated every 1 to 2 years. And the FRAC score should be reevaluated, especially if the patient is on continuous ADT support. Okay. So that's how you decide whether to give, bone strengthening agents along with ADT. Right. So ADT, if we just quickly go over the indications, we'll talk about this in further detail when we talk about, get into the core topic. But quickly go into the indications when you talk about localized prostate cancer, you give ADT in patients who have, non-favorable intermediate risk disease, right? Non-favorable intermediate risk disease, you give ADT and usually give it for 6 months here. In cases of high risk or very high risk localized disease, you give it for a period of 2 to 3 years, right? Now, coming to metastatic, ADT is required in all patients. Okay. So it forms the backbone of treatment in all patients. No patient can be excluded from androgen deprivation therapy. Okay. So that's regarding the indications. Now let's move on to the second set of drugs in systemic therapy in prostate cancer. That is anti-androgens. Okay. And earlier we used to use steroidal anti-androgens. Currently we use non-steroidal anti-androgens. Okay. And these are basically they are competitive inhibitors of for testosterone and dihydrotestosterone for the androgen receptor. Okay. So they inhibit the androgen receptor, they compete with testosterone and dihydrotestosterone for binding to the androgen receptor. So the first generation anti-androgens include biclutamide, flutamide, nilutamide. Okay. Now these drugs they are currently not used actively. The only use is probably biclutamide. We use biclutamide for when you start a patient off on GnRH agonist to tide over the initial testosterone surge, right? So we use it along with GnRH agonists. But apart from that, we currently don't frequently use these anti-androgens, right? Because we have better drugs that are. We don't currently use these first generation anti-androgens because we have better drugs currently. Okay, only biclotamide is probably prominent along with GnRH agonists in the initial phase. Now, what we do use frequently is the second generation of anti-androgens. Okay. Now, how is this second generation of drugs? That is, I'll just name the drugs: enzalutamide, right? And I'll also give the dose. This is 160 milligram OD, or apalutamide, 240 milligram OD, and darolutamide, 600 milligram BD. So, how are these drugs better than the first generation? So, the first generation just competes with testosterone and dihydrotestosterone for binding to the androgen receptor, right? But not only do these second generation anti-androgens do that, they also inhibit signaling in ligand independent fashion. That is, they prevent androgen receptor transport. Suppose testosterone has been it binds to AR. It prevents the transport of the AR into the nucleus. So AR transport into the nucleus is prevented as well. Apart from competing for binding, it prevents the transport of the androgen receptor into the nucleus where the transport is required for its functionality, right? So that is an added mechanism by which second generation anti-androgens are better drugs. Okay, so basically, let's look at some of these side effects, right? So if you look at it by and large, the classic side effects of anti-androgens are you get fatigue, you get hot flashes, right? Um, there's an increased risk for hypertension, right? And so all of this is there. Also, there's increases for ischemic heart disease. But more troubling than all of this is that most of the anti-androgens, especially enzalutamide and apalutamide, can cross the blood-brain barrier and can cause seizures. It can cause falls, right? And can cause stress as well. Okay, so this is the concerning side effects: seizures, falls, and press. Especially if you have elderly patients, they can have falls and fractures also. So this drug is usually not used. That these anti-androgens, especially the second generation anti-androgens, are not used in patients with previous history of stroke, right, or any seizure disorder. Okay, it's avoided, especially enzalutamide and apalutamide. They're avoided in patients with history of stroke or seizure. So that is the basic side effect profile, and this holds true for enzalutamide and apalutamide. Okay, I'll talk about why it's not that common in darolutamide, but enzalutamide and apalutamide, all these side effects hold true. Okay, so apalutamide, if you look at it, it also has a couple of other side effects from apart from these. That is, it can cause skin toxicities and such as rash and pruritus, and can also cause hypothyroidism. Okay. Another interesting thing about apalutamide is that the cardiovascular side effects are lesser compared to enzalutamide. Okay. Now, I kept darolutamide for the end because darolutamide has a slightly different toxicity profile because of its decreased blood-brain barrier penetration. Okay. Because of that, the risk for seizures, the risk for falls and fractures, and the risk for press is much lesser. Okay. Which is why you can consider using this drug in patients with a history of stroke or seizure because of its lesser blood brain barrier penetration. Okay. So, what side effects do we see here? So, of course, we see, fatigue, we see hot flashes, right? Hypertension, all of that is seen. Apart from that, you have a few unique side effects. So, what are those side effects? So, you can get anemia, you can get neutropenia, so basically myelosuppression, right? You can get transaminitis, you can get decrease in calcium as well, and you can get increase in blood sugars. So it's got a slightly unique toxicity profile. Of course, you get your flashes, hot flashes, fatigue, and hypertension, but the risk for seizures, falls, and press is lesser. And it's got myelosuppression, transaminitis, decrease in calcium, and increase in blood sugars. Okay, so this is the side effect profile for the second generation anti-androgens. You should know the little quirks with each agent, right? The unique side effect profiles for each agent, as well as the overlapping ones. Okay. Right. So where are these second generation anti-androgens used? Right. So if you look at the indications, just to give you a brief overview, so they are used in combination. So if you look at hormone sensitive prostate cancer, so if you look at hormone sensitive prostate cancer, that is metastatic. So, right. So mainly they're used in the metastatic setting. So if you look at hormone sensitive setting, then it's used along with ADT, right? So all three agents are can be used as a doublet: enzalutamide, apalutamide, and darolutamide, right? It can also be used as a part of triplet therapy, right? For fit patients who have high volume disease, especially, you can use it as triplet therapy. So there it's given with ADT plus DOSI plus darolutamide. That's what's approved, right? So that's in the hormone sensitive setting. Now, in the castrate resistant prostate cancer metastatic setting, it's combined with ADT, and usually enzalutamide is approved, although we can give apalutamide and dialutamide as well. So here it's given in patients who have not received any of these agents earlier. Okay, so if they're not received an androgen receptor pathway inhibitor earlier, there you can give it in the castrate resistant setting. Okay, so I hope you understood this. So triplet is usually given in high volume disease, right? Certain case of low volume disease, we'll get more into that in the subsequent classes, right? And in fit patients. So here I'd just like to mention one thing, just a precursor to the next class. What is high volume disease? Okay. So metastatic prostate cancer, especially hormone sensitive prostate cancer, is divided into low volume and high volume. This is based on criteria from the chartered trial. Okay, we'll get more into target trial in the next class. But what is high volume disease? So presence of visceral mets, for example, liver mets, for example, or if you have presence of bone mets, that is four or more bone mets with at least one or more, involving bones outside of the vertebral body or the pelvis. So, other than vertebral body or pelvis. So, that is high volume disease. Usually, if you have a high volume metastatic hormone sensitive prostate cancer and the patient is fit, you would want to give a triplet therapy. That is the current standard of care. Okay. So, patients who do not meet this criteria are called low volume hormone sensitive metastatic prostate cancer. So I hope you understood that. So that is regarding anti-androgens. Now let's get into the third class of drugs. The third class of drugs looks at enzymatic inhibition. Okay, and here basically the idea here is to decrease the formation of testosterone. Okay, through enzymatic inhibition in both the adrenals as well as the testes. Okay, so that's what we hope to achieve here. So we can do this by inhibiting an enzyme called CYP17. Okay, CYP17 is a crucial enzyme required for the formation of testosterone throughout the body. And if we can inhibit this enzyme, we can decrease the testosterone production in the adrenals as well as the testes, right? So earlier we used to use these crude CYP17 inhibitors such as ketoconazole, right? But the duration of control was only 3 to 10 months, and there were very prominent side effects. So, because of that, ketoconazole has fallen out of favor. We have a much better drug, a much more potent inhibitor of CYP17, that is abiraterone. Okay. And abiraterone is given at a dose of 1000 milligram. It should be taken 1 hour before food. This is very important to counsel the patient. Okay. So it should be taken 1 hour before food or 2 hours after food. There is also an alternative dosing where you can give 250 milligram OD with low fat meal, but this is not commonly used. It's not been approved in a phase 3 randomized trial. Now, the important point with abiraterone is you should always combine it with steroids. Now, why do we give steroids with abiraterone? The question might arise. So, like I said, abiraterone is a CYP17 inhibitor. So, it decreases testosterone levels. Okay. It also decreases cortisol levels. So, it blocks the formation of testosterone, it blocks the formation of cortisol. This leads to an increase in ACTH secretion from the pituitary. Okay, as a feedback mechanism. Now, this increased ACTH, they go, testosterone and cortisol cannot be made because it's been blocked, right? The levels are decreased, but what isn't blocked is the formation of mineralocorticoids. So ACTH will increase as a feedback mechanism, and there'll be increase in mineralocorticoids, right? And these mineralocorticoids, as we'll talk about later, they have a bunch of side effects, such as fluid retention, uh, hypokalemia, etc. So, to prevent this side effect, right? To prevent this surge in ACTH, we supplement the patient with steroids. Okay, so that is the number one reason to prevent the surge in ACTH and increase in mineralocorticoids. We supply steroids. The second reason we supply steroids is to prevent adrenal insufficiency due to decrease in cortisol. So, due to these two reasons, we give steroids with abiraterone always, right? So, what is the dose of steroids given? So, it depends on the setting. So if it is metastatic hormone sensitive prostate cancer, you give 5 milligram OD on a daily basis. Okay. If it is metastatic castrate resistant prostate cancer, then you have to give a higher dose, that is 5 milligram BD. In this castrate resistant setting, steroids also acts to prevent prostate cancer growth as well. So you give it 5 mg BD in castrate resistant metastatic setting, whereas in hormone sensitive metastatic setting, you give 5 mg OD of prednisolone. Okay. So 5 mg OD of prednisolone or 5 mg BD of prednisolone on a daily basis along with abiraterone. So what are the side effects of abiraterone? As I alluded to earlier, it causes hepatotoxicity. So patients with liver dysfunction, it should be avoided, right? When you're making your initial treatment decision, as we'll talk about in the later on class, in patients with hepatotoxicity, it should be avoided, right? It can cause mineralocorticoid excess. Like I mentioned earlier, that's why we give, Visolon or prednisolone along with it. And this mineralocorticoid excess can cause hypertension. It can cause decrease in potassium. It can cause, fluid retention. All these side effects can happen. And of course, there's a decrease in cortisol production, right? So there will also be adrenocortical insufficiency, right? Adrenocortical insufficiency can be seen as well. So this can manifest in the form of decrease in BP, uh, shock, hypovolemic shock, right? Nausea and vomiting, fatigue, right? Decrease in sodium, increase in potassium, right? And also it can later go into confusion and stupor as well. So all of this can be a manifestation of abiraterone as well, which is why we give steroids along with it. Okay. So what are the indications for abiraterone? So abiraterone is usually given in the localized setting in very high risk prostate cancer only. Okay, so here, along with ADT, and we know we give radiation, right, or surgery. Usually, radiation is preferred in very high risk. So here, ADT plus RT is given. So ADT, as I discussed earlier, is given for 2 to 3 years in high risk and very high risk. So apart from that, you also give abiraterone for 2 years as well. Okay, this is based on the Stampede trial in very high risk localized prostate cancer. We'll get into that later on. Now, in metastatic setting, we give it right. In hormone sensitive setting, we give it as part of doublet with ADT, or we can give it as part of triplet ADT plus docetaxel. So yeah, you can give ADT plus abiraterone as doublet, or you can give it as part of triplet therapy in the form of ADT plus dosi plus abiraterone. And as I mentioned earlier, this is usually given in patients who are fit and who usually have high volume disease. This is based on uh, the Peace One trial. And in castrate-resistant setting, it's usually combined with ADT in patients who have not been exposed to an androgen receptor pathway inhibitor earlier, right? So it's approved in both these settings in hormone sensitive as doublet form and triplet form in appropriate patients, and castrate resistant in doublet form in patients who have not been exposed to ARPI earlier. Okay. So that is an overview of the indication. Now, another interesting thing is if the patient has been exposed to enzalutamide earlier, then the effect of abiraterone, although it can be given on progression, is lesser. Okay, and vice versa. Okay. So once the patient has been exposed to an androgen receptor pathway inhibitor such as enzalutamide or darolutamide or apalutamide, then if you give abiraterone, the effect is lesser, and vice versa. But what should be the ideal sequence? This is not the ideal sequence. If you're giving it, it should be abiraterone first, followed by enzalutamide always. Okay. The reason for this is a phase 3 trial which has shown that this sequencing of androgen receptor pathway inhibitor blockade has a longer survival outcome when compared to giving enzalutamide or apalutamide darolutamide first, followed by abiraterone. Although when you give one, ARPI followed by another, the outcomes are not that good when you give it the second time. But if you're giving it, the sequence should be abiraterone first, followed by enzalutamide, and this is shown to have increased outcomes in phase 3 trials. Okay, so that is regarding abiraterone. Now we'll come to the fourth systemic agent, and that is good old chemotherapy. So when we talk about chemotherapy, we'll start from the beginning. Okay. So initially there was a drug called mitoxantrone, right? That was approved. It's given at a dose of 12 milligram per meter square, 3 weekly. So when this was compared to, best supportive care, what they found was that there was an improvement in quality of life. There was absolutely no OS benefit. So currently, mitoxantrone is used when you have exhausted almost all the lines of therapy, and if the patient is highly symptomatic, it can cause a decrease in symptoms and improve the quality of life. Okay, it is not used upfront. It is not used earlier on in the treatment. It is used much later on when you've exhausted all the, effective lines of therapy. Only if the patient is symptomatic to improve their quality of life. So it's not that important in the current day and age. What is important is docetaxel. So docetaxel is given at a dose of 75 milligram per meter square, right? And docetaxel is usually given in two settings: in metastatic hormone sensitive prostate cancer and metastatic castrate resistant prostate cancer, right? So here it is given as a doublet or as a triplet, right? So this could be plus abiraterone or darolutamide. So usually docetaxel is preferred in high volume disease, right? That is where it gets its maximal effect. It can be used in low volume disease if the mets are synchronous, right? So synchronous metastatic low volume disease, it can be used. We'll talk about that later on, but remember that's predominantly used in high volume disease. That's where the majority of the benefit is there. Now, in castrate-resistant prostate cancer setting, if it's not been exposed to earlier, you can combine with ADT as well. So docetaxel, both in doublet and triplet form in hormone-sensitive setting, is used in high-volume disease. We look at the evidence later on. And in castrate-resistant setting, if it's not been used earlier, it can be used. Okay. Now, as we all know, docetaxel it binds to tubulin, right? And what it does, it stabilizes the microtubules by preventing depolymerization. So it prevents depolymerization by stabilizing the microtubules and preventing cell division ultimately, right? So docetaxel, unlike mitoxantrone, what the trial showed was that it improves the OS, it improves the quality of life, right? So there's an OS benefit as well, which is why it was initially preferred over mitoxantrone, right? And what are the pre-medications required? So the pre-medications, we know that docetaxel you need to give steroids, right? So usually when you give it in the hormone-sensitive setting, you have to give prophylactic steroids, tab dexa, 8 milligrams BD, day zero, that is 1 day prior, on day of chemo, and 1 day after. Okay, so this is the regular pre-medication for docetaxel. It's to decrease, peripheral edema. It's to decrease hypersensitivity, right? So this is what's usually given with docetaxel, and this is definitely what we give in the metastatic hormone-sensitive prostate cancer setting. But in the metastatic castrate-resistant prostate cancer setting, you cannot give docetaxel alone. You give docetaxel plus steroids in the form of prednisolone, right? 10 mg OD or 5 mg BD. So this is given because that also acts against the prostate cancer cells, prevents prostate cancer growth in castrate-resistant setting. So this is not required. This prednisolone is not required in the hormone-sensitive setting with docetaxel. So because you're giving prednisolone, you also need to give DEXA, right? Because the side effects of hypersensitivity, the side effects of peripheral edema and fluid retention is still going to be there. So you need to give DEXA, but because you're giving prednisolone as well, DEXA needs to be given in the DEXA pre-medication needs to be given in a different manner. So let's look at how it's given in this setting of metastatic castrate-resistant prostate cancer, where you need to give prednisolone 10 mg OD daily as well. So there you give DEXA like this, DEXA 8 milligram, and this is given 12 hours, 3 hours, and 1 hour before the docetaxel infusion. So this is a slightly different way of giving docetaxel pre-medication dexamethasone in metastatic castrate-resistant prostate cancer. So I hope you remember that. Um, that is also very important. Now, we know the side effects of docetaxel, like I mentioned earlier. It can cause, myelosuppression. It can cause alopecia. It can cause peripheral edema. It can cause, um, peripheral edema, myelosuppression, alopecia, and it can cause neuropathy, although that is much lesser than paclitaxel and other taxanes, right? So those are the major side effects. Now coming to the third drug, this is cabazitaxel. So the issue with all these drugs, such as your docetaxel, for example, is that the major resistance mechanism for docetaxel is the development of a MDR phenotype. That is a multi-drug resistance one pump phenotype. Okay, so this is an efflux pump. This is also called the uh, GP glycoprotein P efflux pump as well. So what this does is it effluxes the drug or pushes it out of the tumor cell and prevents its action on the tumor cell. Okay, so that is the major resistance mechanism for docetaxel. Now, cabazitaxel can be given post docetaxel in the metastatic castrate-resistant prostate cancer setting. Why can it be given? Because this cabazitaxel is not, affected by this resistance mechanism. It's not a substrate for the MDR1 efflux pump. Okay, so not a substrate for the MDR1 efflux pump. So because it's not a substrate, it's retained within the tumor cell even post docetaxel when the resistance mechanism emerges, and it can act on the tumor cell in that setting as well. So where is it approved? It is approved in metastatic castrate-resistant prostate cancer post docetaxel. Okay, so initially a dose of 25 milligram per meter square, 3 weekly was approved. This was based on the Tropic trial. But later on, there was another trial called the Proselica trial, which looked at a dose of 20 milligram per meter square, 3 weekly. They compared this to 25, and they found that there were no differences in outcomes and less toxicity. So now 20 milligram per meter square is preferred. For elderly patients, there is another dose of 16 milligram per meter square, which is given every 2 weekly with growth factor support. Right? This is based on the Capacity trial, and they found that this, when given with growth factors at a dose of 16 milligram per meter square every 2 weekly, there is less myelosuppression. Okay, so these are the various dose formats for cabazitaxel. Now, coming to the side effects, right? If you look at the side effects, it's predominantly myelosuppression. Okay, so that is what we look out for with cabazitaxel. Okay, so apart from this, there's a fourth drug. That is carboplatin. So carboplatin can be combined with Kabasi, especially in the so it can be combined with Kabasi, especially in the metastatic castration prostate cancer setting, right? Especially if it's aggressive disease that's rapidly progressing. Okay. So in that setting, it can be combined with cabazitaxel, or in the setting of a p53 mutation, a p10 mutation, an RB mutation being present, there also can be combined with cabazitaxel. Or if there is an underlying BRCA mutation, there we know that platinums have better action, so there also can be combined with cabazitaxel in the metastatic castrate-resistant prostate cancer setting. Okay, so that is one drug that can be used in certain scenarios. Okay, so that brings us to the end of systemic therapy in prostate cancer, right? The next class will be on the management of metastatic hormone sensitive prostate cancer and metastatic castrate resistant prostate cancer. So, hope you guys understood this, all the concepts discussed today. Thank you very much.